Hello, I'd like to thank Jay Wu, as well as the Symposium for Inflammatory Skin Disease for the invitation to speak. My name is Brian Kim. I'm an Associate Professor of Dermatology at Washington University School of Medicine. I'll be talking today about Dupilumab, type 2 cytokine blockade, and how these therapeutics actually may fit into the emerging therapeutic landscape in the coming year, as well as how biologic mechanisms may be increasingly important in terms of understanding uh, not just the mechanism of action per se, but also what we can anticipate we'll see, if not have been seeing, in clinical trials as well as post-market. Here are my disclosures. So itch is a central feature of atopic dermatitis or eczema. We all know that. It's the single most important kind of morbidity in this condition. However, it hasn't been until recent years that we came to actually appreciate what the mechanisms are that actually drive itch within this condition. A central focus of our laboratory has been actually trying to understand what are the molecular and cellular mechanisms that actually drive healthy skin to become inflamed skin. Essentially, how do we get the rash? When we actually first embarked on these studies, it was well appreciated that inflammatory stimuli or even allergens can actually somehow mysteriously activate this adaptive T helper type 2 or Th2 cell, which is marked by an antigen-specific T cell receptor. The antigen to this day is unclear that actually drives this process and results in the production of what we now refer to as type 2 cytokines, IL-4 and IL-13. This actually recruits a variety of different inflammatory events that underlie or drive the pathogenesis of atopic dermatitis. We see activation of mast cells, production of IgE, and direct damage to the epithelial barrier secondary to the production of these type 2 cytokines. In our work, we came to appreciate that other cytokines upstream of this process, including IL-33, as well as TSLP, which are epithelial cell-derived cytokines coming out of stress keratinocytes, can actually broadly activate this pathway. What we found was actually downstream in recent years of these pathways that other innate cells, like circulating basophils that get recruited into the skin, as well as previously unrecognized group 2 innate lymphocyte cells, or ILC2s, collectively are major sources of the type 2 cytokines IL-4 and 13 and are major drivers of the pathogenesis of this disease, expanding our understanding of what cells contribute to this well beyond T cells. So if we're going to talk about the type 2 immune response, which I'll be talking about quite a bit throughout this talk, it's important to understand how this immune response actually fits into the context of the global host immune response. Well, the type 1 immune response, which is a separate module, is very, very important for antibacterial as well as antiviral immunity. This arm of the immune response is derived from both adaptive T cell as well as innate natural killer cells. And in general, by way of the production of cytokines like interferon gamma, also TNF-alpha, are key effector cytokines in this process. If this immune response is overly active, we know that a variety of autoimmune processes can be triggered, such as inflammatory arthritis, psoriasis, and a variety of other disease states. But we also know is that the type 1 immune response is very much responsible holistically in terms of balancing the type 2 immune response, which was originally evolved for anti-helminth immunity. We know that type 2 immune response is very important in its exaggerated forms and causing a variety of different atopic disorders. But the point here really being that whether we're talking about adaptive T cells or innate cells, that there is a counterbalancing mechanism that results in homeostasis and health. It's when these immune responses are perturbed or imbalanced that we start to see a variety of different inflammatory disease states. We have actually shown just in the last year that just within the innate compartment, the balance between natural killer cells and ILC2s is very important to maintain a healthy skin barrier and avoid the development of atopic dermatitis. In fact, what we found is that if we use therapeutic drugs to actually boost NK cells, what happens is that we then suppress innate ILC2 responses and are able to actually suppress atopic dermatitis-like inflammation. So again, emphasizing the point that even with atopic dermatitis, a healthy balance between the type 1 and type 2 immune response is very important. I think that this is very important to understand in light of the fact that we can now intervene on these different immune axes therapeutically within the context of atopic dermatitis, and hopefully it'll become apparent why that this is clinically relevant. In recent years, we've come to appreciate different mechanisms by which the inflamed skin can actually trigger various molecular and cellular processes that elicit itch, and being, again, a major feature of atopic dermatitis. To understand itch, we have to look into the nervous system, and to make this relatable, I like to talk about histamine. If we actually inject histamine into the skin, what we find is that histamine binds its receptor, like H1R, which is dependent on other channels like TRPV1, which is the receptor for capsaicin, and histamine can actually activate an electrical impulse in the sensory nervous system to trigger itch. One thing that's been disappointing about histamine is that antihistamines have not generally been very efficacious for the treatment of chronic itch and atopic dermatitis, as well as other disorders. However, that we came to appreciate, and new hope came by way of the cytokine IL-31. IL-31, which was originally reported to be produced predominantly by adaptive Th2 cells, we now know can act like a neurotransmitter, activate its receptor, IL-31 receptor on sensory neurons, and despite activating a very small percentage of the sensory nervous system, is very important for itch. And there are now therapeutics, which I'll talk about in a moment, that can block this pathway. Well, understanding that IL-31 is implicated in this kind of neurotransmitter-like response, we in recent years came to ask a very simple question, which is that could classical type 2 cytokines like IL-4/13 also engage the sensory nervous system to modulate itch? My graduate student, Landon Etchen, discovered in 2017 that, in fact, if you extract sensory dorsal root ganglia from both mice as well as cadaveric human donors, you can detect expression of both IL-4 receptor alpha, the receptor for both IL-4 and 13, and the target of Dupilumab, as well as IL-13 receptor alpha-1 from the dorsal root ganglia. And as you expect, based on what I told you, we could reliably detect IL-31 receptor. The expression pattern is conserved between both mice and humans, indicating and suggesting a shared physiology. So based on these findings and our published work, we found that in fact these receptors are very important and functionally, and it's really started to expand our paradigm of how we understand itch, and as well as these inflammatory pathways. We know these pathways like IL-4 receptor alpha, as well as the JAK-STAT signaling pathway downstream, are very important for a lot of the pro-inflammatory events within the immune system. But what we also now appreciate is that these different cytokines can actually act directly on sensory neurons and have very distinct neurologic effects on the host as well, like itch. Well, classical agents in atopic dermatitis have not generally been targeted in this fashion. We know that on the left here, we have approved and common treatments like topical steroids, calcineurin inhibitors, wet wrap light therapy, all variably effective, but again, not specific in terms of the anti-inflammatory effects. But also the potent immunosuppressive agents shown here on the right, also, although potent and broad, are not particularly effective, not always the most effective treatments, are fraught with side effects. And despite being very broadly immunosuppressive, as I mentioned, are a little bit disappointing in terms of the consistency with which these therapeutics work, indicating that being targeted does not necessarily result, perhaps, in losing out in terms of efficacy. And we know this now because of the approval of Dupilumab in 2017, which really revolutionized our understanding, as well as the treatment of moderate to severe atopic dermatitis, but also our understanding of this disease in many ways. And we now know that more targeted treatments can be both safer as well as more effective. And I believe that that's the case with Dupilumab. What was very important and what was so revolutionary about the clinical trials for Dupilumab is that it really set the standard for what the clinical endpoints would be in this disease. On the left here we show an investigator global assessment, and of course, Dupilumab clearly showed improvement compared to placebo that was very significant in terms of the investigator global assessment scores, as well as reduction in terms of the eczema area and severity index, 75 metric. But also secondary endpoints came to be appreciated as to be very important in atopic dermatitis, such as the pruritus numerical rating scale, itch score, and the reductions in the pruritus level have become essentially a gold standard readout for the value of a new therapeutic in atopic dermatitis. And Dupilumab has really paved the way in terms of our understanding here. Again, this is just a highlight in contrast to very non-specific therapeutics, which really try to get at the disease in a very aggressive and non-specific way. We believe that targeted therapeutics act like missiles that really take out the precise target that you want without causing much in the way of collateral damage. And we believe that this is kind of the future that we're living in terms of therapeutics for atopic dermatitis. So how do emerging therapeutics for atopic dermatitis work? It's actually a little bit more complicated, I think, than we often appreciate. We know that Dupilumab blocks the IL-4 receptor alpha, and it blocks the binding of IL-4 to its receptor, which is a combination of the IL-4 receptor alpha as well as a common gamma chain. So this is how we block IL-4, by blocking this subunit. But also we know that we can block IL-13 by Dupilumab blocking the IL-4 receptor alpha and preventing this receptor subunit from heterodimerizing with the native IL-13 receptor alpha 1. We now know also there are new emerging therapeutics like lebrikizumab, which actually bind up IL-13 itself and block binding of IL-13 to this receptor as well. Of course, this would have no effect on this signaling pathway here on the left in terms of IL-4, which would be able to commence unchecked. There's also the therapeutic in development, tralokinumab, which blocks IL-13, much like lebrikizumab. But in slight contrast to lebrikizumab, what tralokinumab does is it actually also blocks the ability of IL-13 to bind the IL-13 receptor alpha 2, which is a decoy receptor. In many ways, one could argue that allowing IL-13 to bind IL-13 receptor alpha 2, which binds it up, is actually a good thing, and you don't necessarily theoretically want to block IL-13 from blocking its decoy receptor, which a bit controversial, is thought to just be a pure decoy and does not actually signal, but really acts like an IL-13 sink. And then IL-31, which I mentioned earlier, nemolizumab is a monoclonal antibody that blocks IL-31RA, which is a subunit for the IL-31 receptor, which heterodimerizes with the OSMR subunit shown here. So again, this is IL-31 is blocking at the receptor level. So, and these are all associated with the type 2 immune response. And so now we have a variety of different monoclonal antibodies that can block these pathways in different ways. The overall current atopic dermatitis trial design paradigm involves typically adolescents as well as adults, monotherapy or concomitant topical steroids. They tend to be on the order of 16 weeks long in terms of the treatment period. And then there's increasing focus now on secondary endpoints of itch as well as quality of life. What are the primary endpoints? I've already alluded to this in atopic dermatitis clinical trials. They're the eczema area and severity index, 75. So how many patients can actually generally achieve 75% improvement in terms of the EASI score. The investigator global assessment, reduction to 0 or 1 with greater than or equal to 2 reduction from baseline. So, and then the secondary endpoint is a critical secondary endpoint is the numerical rating scale itch score, is how many patients can actually achieve a greater than or equal to 4-point reduction from baseline in terms of their numerical rating scale itch score on a scale of 10. So these are the primary and secondary endpoints that are gold standard for atopic dermatitis. And what I'm going to do here now is kind of give a high-level overview of how Dupilumab and these new therapeutics stack up against each other by comparing across trials. This is often discouraged, but I also think it's very important to see how these things stack up to get a global, high-level sense of how these therapeutics will actually emerge into the landscape. Some trials use slightly different endpoints, so that's another disclaimer. Some use more of a continuous outcome, percent reduction, rather than percent achieving a specific outcome. So a dichotomous outcome, which is generally much more, a bit more rigorous. Some have 12 weeks versus 16 weeks as the timeline. I'll focus almost exclusively on monotherapy here, and mostly I'll try to talk about phase 3 data. And what I've actually done is actually really tried to kind of highlight these therapeutics by kind of normalizing them against each other and reanalyzing the data so that we can kind of compare across different trials. So the first question is, what is the efficacy of classical type 2 cytokine blockers? As I mentioned, there are anti-IL-13 monoclonal antibodies, and if we look at EASI-75, we have the Tralokinumab shown here on the left in terms of patients achieving EASI-75%. This trial definitely showed that 300 milligram Tralokinumab clearly beats out placebo. And then we have Lebrikizumab on here on the right. This is actually a phase 2b trial. So it's actually a dose ranging study with different frequencies of delivery of Lebrikizumab. Here we have Q4 weeks. In the red, we have Q2 weeks. And what we see is a dose-dependent improvement in terms of the EASI-75 endpoint. How does this generally stack up against Dupilumab? What we find is that they're in the same kind of range. We think Tralokinumab may be not quite meet the Dupilumab level of efficacy, whereas Lebrikizumab seems to, particularly at the higher doses. And so we have a general sense now of how these kind of stack up to Dupilumab. Of course, again, as a disclaimer, these are not head-to-head. In terms of the investigator global assessment, again, the Tralokinumab beats out placebo, and that's shown here on the left. Dose-dependent increase in terms of efficacy with IgA, with Lebrikizumab as well, looks much like the EASI-75. Here's Dupilumab. It looks like at the highest doses, you might actually see Lebrikizumab could beat out Dupilumab. We'll have to see what the phase 3 on this study actually shows, whether this itch is much more pronounced in terms of the effects in Lebrikizumab. The Tralokinumab looks very much in line with what we see in the EASI-75 and the IgA, but we start to see this kind of inflection a bit at the highest doses of Lebrikizumab in terms of the NRS itch score here. And in the dotted line, again, we see Dupilumab. So how might these antibodies be different from Dupilumab? I talked about the mechanism of action here. Dupilumab blocks IL-4 at 2 different receptors, but also blocks IL-13. Lebrikizumab, Tralokinumab only block IL-13. Tralokinumab additionally blocks IL-13 from binding its decoy receptor, which may, it could be inconsequential. It could be less favorable to do this because this really acts as an IL-13 sink. So here's Dupilumab. So it would prevent downstream signaling both here. Lebrikizumab would block downstream signaling here. Tralokinumab would also block downstream signaling. It's thought that IL-13 receptor alpha signaling is a decoy, so it really does not signal. There's some controversy about that. So it's possible, based on the fact that there are, at the receptor level, different mechanisms of action with Dupilumab, that we may see a slightly different profile of these drugs. That would actually be the hope, because we now know that there are some post-market adverse events that we've seen with Dupilumab. We've seen patients with paradoxical facial dermatitis where they may actually improve on the body, but then develop or have an exacerbated facial dermatitis response, as shown here in these 2 individuals. We also have a number of patients who develop a conjunctivitis as well, despite improvement on the body with Dupilumab. It's possible, based on the mechanism of action, that these side effect profiles may actually be different in the context of IL-13 antibody treatments. But this is speculation. We'll have to see, based on clinical trials, but also post-market, whether these kinds of rare events are different. Now, going to IL-31 blockade. So what is the efficacy of IL-31 blockade? As I mentioned, Nemolizumab blocks IL-31RA, so it blocks IL-31 signaling on this receptor. And how does this stack up? The difference here is that this is from a phase 3 trial readout, but this was more of a continuous outcome rather than a dichotomous outcome. And here, instead of using the numerical rating scale itch score, this was actually a visual analog scale, which is very similar, very similar. And what we show here is that perhaps comparable or almost comparable in terms of itch with dupilumab for nemolizumab. In terms of EASI reduction, we see that it's probably a little bit less. Again, it's really hard to know comparing across trials how this will really hold up, but at least we get a preliminary sense of where nemolizumab and IL-31 blockade actually stacks up in the current emerging therapeutic landscape. So coming back to this idea of a type 1 versus type 2 immune response, is this relevant? Does this actually play out in the real world? It's possible. We're actually seeing now in real world immunology that there are now reports of dupilumab in the development of inflammatory arthritis, enthesitis, arthralgia, even psoriasis like dermatitis. So it's very possible now that in terms of therapeutics like dupilumab, that they're so effective at blocking the type 2 immune response that in some individuals with a type 1 predisposition or proclivity, that we could actually bring out more type 1 responses, and that is in part why some of these events are observed. It's hard to know. These are very much case theories that have been reported, but it'd be interesting to know how this plays out, and also important to see how this plays out with IL-13 blockade as well. But we know also that these cytokines have to signal through the JAK-STAT signaling pathway, and there are a number of JAK inhibitors in development. And but what's interesting about the JAK pathway is that it blocks so many different cytokines, not just along the type 2 axes, but also the type 1 axis. Shown here, interferon gamma is blocked in part by JAK1 as well. And we can now see how JAK inhibitors, particularly pan-JAK or JAK1 selective inhibitors, may broadly block inflammatory axes, not just type 2 in atopic dermatitis. And in fact, we see with baricitinib, abrocitinib, upadacitinib, with these 3 different JAK inhibitors, there's clearly efficacy in atopic dermatitis. The question is now, how does this kind of compare? Here's EASI-75 to dupilumab. It's not unlike what we see with the other cytokines, that some of these actually at higher doses may actually beat out dupilumab while others may not. But what I would speculate here is that with the JAK inhibitors, we may see less of type 1 immune responses emerging. Maybe perhaps we'll see less of these kind of paradoxical inflammatory events as well. Hard to say, this is all speculation, but the point being here is that JAK inhibitors are, although specific, are still relatively broad in terms of cytokine blockade and do not necessarily favor only type 2 immune responses, but also block type 1 responses as well. Here is similar for these 3 JAK inhibitors, IgA score improvement. Again, dotted line dupilumab, it tracks very similarly with the EASI-75 as well. Itch looks very similar as well. At the highest doses of abrocitinib and upadacitinib, it seems to actually beat out dupilumab as well. So what we think is that whether we're talking about type 2 cytokines or as well as the JAK-STAT signaling pathway, that in addition to the anti-inflammatory effects of these therapeutics, that a lot of the profound effects we see on itch may in fact be due to the the neuromodulatory properties of these drugs. And it'll be interesting to see how this all really plays out from both the clinical trials as well as in the post-market success of these various therapeutic agents. I'd like to think I did present some of the actual work that came out of our lab and framed it into the context of the therapeutic landscape. So I'd like to thank all the members of the laboratory who put that kind of work in. I highly featured Landon Etchen's work here, who's now left the lab and is now a neurology resident at Harvard, our funding agencies, and our collaborators. And Last but not least, I'd also like to thank our patients who've been involved in our clinical studies as well as our clinical trials. And thank you all for listening.